All right, good afternoon, and welcome everyone this afternoon to the John Peter Smith Network Board of Managers meeting. Thank you all so very much for being here. I have some children playing with flashlights over here, but other than that, everything else is fine. But we would like to start with our opening prayer, and I'd obviously ask our Director of Pastoral Services, Ms. Leanne Franklin, to come up, and immediately following that, if you'd join me in the pledge, I'd appreciate it very much. Thank you. Leanne.
We gather today in this season of hope, and we give thanks to you, O Holy One, that you are the originator of hope. We thank you that you not only offer us hope, but you ask us to be hope, to manifest hope, to create hope for those who need hope most. And so we ask that you grant us your wisdom, that you inform our thoughts, and that you unite our spirits so that we can do and be and create hope for all those who JPS serves. In your holy name we pray. Amen.
Amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I've been advised there's no citizens, therefore we will move to item number 4 on the agenda, which is the approval of the November 9th minutes. They have been on the portal and presented to you, and we would certainly, if there's any discussion, if not, I'd entertain a motion for approval. I have a motion by Mr. Montgomery, second by Mrs. DeBose. All those in favor say aye. Aye. Thank you all very much. I know the next item calls for the board chair's comments, and I think at this time of year, it's only, I'm just going to say two things. One is, we just heard the word hope used several times in our prayer, and I want to take this opportunity to again, I hope each and every one of you and your families have an outstanding and a Merry Christmas. We think of others, not only ourselves during this time of year, and also to the board for the work you've done this year. We here are in December reflecting on what the opportunities we look at going into 18, and we think there'll be many good opportunities for this hospital in the district. So again, Robert, to you, the staff, to the board, and to all our many employees, we want to take and wish you a very, very Merry Christmas. So after that, Robert, I'll turn it over to you for any other CEO report.
You bet. Thank you, Mr. Chairman, and thank you all in the audience and those watching live streaming. Would echo your kind words, Mr. Powell, and also tell you that we've had a few busy months here. When you get towards the end of an actual calendar year, everything tends to be a little bit busier. But one of the things that we did, and I'll give my thanks to Dr. Ziegler and some of the surgeons. You know, I kept you all up to date on the RFP process that we do with our major folks and the major folks that provide services to JPS. And on December the 11th, we had some new surgeons come in, and we have a new surgery direction and a new approach, and that went without an event. Those kind of things can appear sometimes to be a Y2K event, where people will sit back and be very concerned. But I will tell you, thanks to the surgeons that stayed and became a part of JPS, thanks for some of the applicants from around the nation that became a part of JPS, I think we have a surgery department that is going to take a very forward view towards JPS and our patients, and I couldn't thank them more for that, and I appreciate that. So we have a good many of our colleagues who were with us before, but there are some leadership changes, and there is probably going to be some new direction that is going to be very patient-centered, and I'm very proud of that. And Dr. Ziegler, I want to thank you for being a part of that surgery team and the others of your colleagues, and then the new ones that we have coming in. I think we've got a great situation for our patients, and I'm proud, and I will keep you up to date on how that goes. We have, as you all know, if you're in the hospital business or you're in the healthcare business, Joint Commission is a situation where you've got a group of outsiders coming in and looking at how your health network is providing its care, how you're doing with life safety standards, and you go through a periodic time period by which they come in and they review you. That can be for some a little bit stressful. Anytime somebody comes into your house and says, I want to see how you clean your floors and wash your windows and make your bed, that can be a bit challenging. But we welcome the Joint Commission, and we're looking forward to them coming. I just wanted to tell you that we are doing as much preparation as we can. However, we're not doing preparation for Joint Commission. We're doing preparation for being the best organization we can be. If you look at Joint Commission as a visit, you're making a mistake. If you look at Joint Commission as something that helps you become better for your patients and a better workplace for your employees, you're doing right. So that's what we're doing. We're working really hard to try to figure out how to make this a better organization. So we welcome Joint Commission when they come, and we're preparing for them, obviously, for their visit. That can be between now and April, I believe. So they give us a window of opportunity. So we're looking forward to that. Laura Burnside and her team in patient relations had a wonderful opportunity by which we provided breakfast, which we called the Patient Experience Breakfast. And what we did at that is we recognized those that are performing the greatest on some of their overall scores. Now, we realize for you as board members and we as administrators or those who are employees here, not everything is a number. In fact, if you get too number-oriented, you forget the cause of that number. The cause of that number is a human. It is the patient. It is the care. It's the touch of their hand and the services we provide. But there also is an empirical unit by which you apply to that. And that empirical unit says, what are you doing for your patient satisfaction scores? How do you respond to patients? Are you quiet in the hallway? Are you respectful of other people's needs? And there is an actual numerical basis given to that, and that's looked upon by our federal government and rewarded in payments that come back and withhold in monies that are not rewarded to those hospitals that are doing well. We've had some outstanding numbers that have come out of JPS, and what Laura and her team did, and what was scrolling earlier were a lot of those pictures of our doctors and our employees celebrating that time period, is we had a variety of those that had scored some incredibly powerful numbers, such as our 2 South for inpatient care. They were in the 97th percentile of overall patient care. 2 North was in the 90th percentile. Our Barden Road Ortho was in the 73rd. Our South Campus is doing very well. Even our housekeeping and what we're doing in housekeeping. All 3 of our women's health clinics were doing incredibly great work with their percentile rankings. Our emergency department, and that should speak volumes to all of you as board members, but particularly to Mr. Petty and Dr. Weber, who played such an instrumental role when we started making major changes in the emergency department. Our ICU is in the 87th percentile overall for their patient SAT scores. And I'll tell you that we have a very demanding ICU. From the acuity of care and the challenges that we have there, it's exceptional. Our NICU is in the 86th percentile, and T7, our Tower 7, and the great team that went up there. So to everybody that does such hard, difficult work to make things better, again, these are number related, but we don't look at it as number related, we look at it as people related. And so I'm really proud, and that was a wonderful breakfast that the team had. Yesterday in this very room, since this is the only room we have at JPS that has any size to put more than 12 people in it at one time, we have every function possible from board meetings to seasonal sweets and treats. And what we did yesterday is we celebrated a little bit of time and had everybody come by and grab a cookie or grab something that makes you just feel a little bit warmer during your day. This year we advanced enough to have actual brownies that were non-sugar brownies. They happened to be popular for the folks that did not want the sugar intake. That was actually J.R. Labby's station over here in the OPC, and I think it was Scott Rule's station over in the pavilion. So that worked really well. The concern I got was that Scott ate more of the brownies than he gave out, but that will be analyzed later. A bit of a problem.
Don't go there, Trent.
We had some really good situations also happen in the community. We received an award from the Women's Center from the Garden Club, from the Fort Worth Garden Club, on some of the things that we're doing down there for making our landscaping look good. Proud of our landscaping team. That just speaks to the fact that when you come in here, we want to look good for you and want you to feel good. You all may be familiar with the Parade of Lights. This year, our float actually won an award. We, in our own minds, have been winning awards many times for our float, but this was an actually community-recognized award. We won the Founders Award, and so we're really proud of that. And it's also a nice thing that our team does when we go out in the community and become a part of those kind of activities, from a bus pull in the Northeast to a situation that we have here for our parade. JPS is a real consistent partner in this community, and we like doing fun events. So that was kind of a neat night. We had our talent show for those who come to our talent show, and particularly our judges, like the esteemed Dorothy DuBose, who is a judge emeritus. We gave the award this year, or I did not. They gave the award to a group of our employees who are drummers and have our first generation Americans, and they are drummers of high expertise, and we had them on our float drumming for 4 hours. So they drummed before the parade, during the parade, and after the parade. And so they're still drumming. So I think the award was really an endurance award for who could drum the longest. But it's a really neat deal, and it was a nice function. It's neat to see JPS out in the community and the recognition that we get. So, Mr. Chair, from the recognition of our patients and our scores, from the recognition to parades and landscaping, and just surrounding oneself with really great people, it's a blast.
Again, Robert, you and the employees, we appreciate all you do community-wide, and I think it goes without saying, there is always something going on that JPS is involved in. So, which will bring us to the next item, which is item number, excuse me, Ralph, yes.
I just want to ask Robert, we had a board meeting some time ago, or it was either at finance, that we were contracting with an agency that was going to be working with staff prior to joint commission. Mm-hmm. They are still present?
They are. They're still present. We have two of those individuals. They came here and did basically a mock survey for us and walked through every aspect of it. And then we retained two individuals to be here on a weekly basis for us to actually walk the halls and help us get to where we need to be. And they've been very, very helpful. Good point. Thank you.
Yeah, good follow-up, Ralph, because we need to make sure we get that handled right. Item number 7, obviously, Dr. Ziegler, I'll turn that over to you for a report from the medical executive staff, and I'll echo what Robert says. Appreciate your leadership during these times.
Thank you, Mr. Powell. We did lose some of our members. They had a private practice, and they chose to pursue more of their private practice and to stay with JPS. But we're very fortunate. We had today we had a meeting with our new breast surgeon. She's been here for a few weeks. Our new cardiothoracic surgeon, our new plastic surgeon. So the transition has been pretty seamless. So we're excited about the future. We've had our orientation with the claim, and that went very well. So I think we're very optimistic. For the board that I have today, there are the medical executive committee has nominated Dr. Fowler for chairman of the chairman for the family medicine, and also Dr. Jason Brewington as chairman, vice chairman of the family medicine department. Sorry?
No,
family medicine.
Internal is not up today yet. They still have a vote to go.
Right. So Dr. Fowler just recently joined us. Dr. Fowler did his training at the University of Texas at Houston. It's where he has also was vice chairman of the Department of Family Medicine at Houston. He's written numerous articles. He's also the author of the book, the Feniger and Fowler book, Procedures for the Primary Care Physician, which was a highly rated book by our family medicine residents to read before. Now it's become more or less mandatory for them to read. Dr. Brewington got his medical degree at Meharry Medical College in Nashville. He did his residency here, and he's been on staff since 2009, and has been working with several of the aspects of family medicine. So these two have been nominated by the MedExec for chairman and vice chairman of the Department of Family Medicine.
Great. Based on that recommendation coming from Dr. Ziegler, we'll have to do these separately, but I would certainly entertain a motion for Dr. Grant Fowler.
Dr. Grant Fowler and Jason Brewington for vice chairman.
Gotcha. And Neil, we need to do these individually. Let's take Dr. Fowler first. I'd entertain a motion. If that's coming as a motion, then we just need a second.
Yes, it's a motion.
I have a second. I have a second by Dr. Weber. All those in favor say aye.
Aye.
Same situation.
Dr. Jason Brewington for
Dr.
vice
Jason
chairman.
is being recommended. I have a motion. Do I hear a second? I have a second by DT. All those in favor say aye.
Aye.
And thank you very much. Anything else for the board?
And one final thing, our medical staff meeting is this weekend. It's Saturday at the Petroleum Club, starting at 6 o'clock, and we all appreciate if you could, you're all welcome, you're all invited. If you do come, please RSVP. Like Dee Dee Cunningham down in the medical staff office would like to get a head count.
Okay. All righty. Any other questions that we would have for Dr. Ziegler? Dr. Ziegler, thank you very much. We will now move to the report from the acclaim. Dr. Johnson.
Sir, thank you, Mr. Chairman. To start, I know one of the topics you often like to hear about is recruitment. Recruitment continues to go very well. We have 30-ish positions that are currently open, and again, have candidates for most of those. With that said, as per the discussion last month, one of the things that we've seen with the implementation of the compensation plan on the physician side is that productivity has increased, particularly in the primary care, with our current complement. So we're currently undergoing an assessment of how many of those open positions really are needed open positions. So things are going well there. We have our recruiters and physician services team has done a remarkable job with onboarding for many physicians, including the surgical group. Revenue cycle continues to perform well. I'm very pleased with the current state of financial activity, as you'll see in the financial statements, or you will. We for the first couple of months of this fiscal year have performed favorably to budget. That concludes my report, sir.
Any other questions for Dr. Johnson? Thank you very much, James.
Thank you, sir.
The next item, and we get into committee reports, I would like to say we're going to pull item number K on the consent. I'll go ahead and mention that now. That item will be covered under Mrs. DeBost under the Human Resources Committee report. So if you'll please make that notation. And then I would be glad to move forward with the Finance Committee. And Mr. Montgomery, I'll turn it over to you.
Thank you, Mr. Chairman. We had a Finance Committee meeting on December 7th. It was somewhat abbreviated because we moved the schedule of the meeting. We didn't have the financial review from the prior month, but we will have two in January. So everyone attend January's committee meeting. And we did also not hear our BKD audit. We're going to push that. I think it's going to actually be heard today. Other than that, I think there were about 10 contracts that we passed forward for the board's consideration. That's it.
All right. Thank you, Mr. Montgomery. As you will know, even on consent, and I was at Finance, and there's a lot of things at year-end just need to get, they're all tied to year-end as far as renewals or whatever. So thank you, Steve. Appreciate it very much. Mr. Bose, we'll now go to the Human Resources Committee report and turn this over to you.
All right, thank you. Our committee did meet on December the 7th. We have some policies on the consent agenda, but I would ask Bill to come up and present our annual plan results for that. That was part of what we met on. I thought it would be good for the entire board to hear it. Okay.
spirited discussion last Thursday in our HR meeting relative to
Which one are you looking for, Joel?
the 17 actual.
Go back.
Yeah, we're going to review the 17 actual incentive plan performance, the outcomes. It was color-coded in such a way that would be very visible in terms of what we accomplished for the year. We spent a lot of time talking about the 18 proposed incentive metrics as well. And while I've got those up, we might as well just talk about them, because I think what we would like to do as an organization is to present these to you for preliminary approval.
Well, it looked pretty good what's on the screen right now.
We feel really good about it.
I mean, the colors are great.
That's what we should be rewarded for.
Wow.
Okay.
I've lost control of this meeting.
One of our
No,
metrics
that
is
ain't
gonna be
where
our
we wanna
technology
be.
and how much we can hit the buttons.
Oh, I won't do this again. Okay. That's not it.
What you were saying,
This is embarrassing.
Nah, it's,
Yeah.
yep,
as long as the report's good, we can report it.
it's
Let
good.
me just set the stage.
Yeah.
So hopefully, we're going to see a slide that shows you about 9 different metrics that we were focused on last year in attempting to achieve some very specific performance levels around quality, around population health in terms of days to next third new appointment, in terms of service, CAP scores, ED, CG, HCAPs. We had several financial stewardship metrics and employee engagement metrics.
There.
There it is.
Okay,
See? All right.
okay.
Did need a bit of help on the report is over. So, back to the quality. This was a plan that the board reviewed last year, approved the individual indicators, the goals, and the performance levels associated with each of those goals. Last year, we focused on reducing catheter-associated urinary tract infections and reducing falls with injuries. So we attempted to show you where we ended up the year relative to those performance levels. So our goal was a threshold of 10, a target of 7, and a stretch target of 0. We had 8 CAUTIs for the year. In terms of reducing falls with injuries, we had 1, which is quite remarkable for an organization our size. Now, that's not to say we only had 1 fall. We had 1 fall with injury, and there's a big difference between that. And we need to focus on reducing our overall fall rate. But we almost hit 0, and that's the journey that we're on. Improving days to next third new appointment under population health. We finished fiscal year 16 at 3 clinics had availability for new patients in less than 25 days from call. We wanted to improve that to at least 4, 5 for a target and 6 for a stretch, and we ended up the year at 4. So it's an improvement, not where we want to be, but we did hit the threshold mark there. In regard to service, you might recall that we hit the 78th percentile in HCAPs last year. That was a marked improvement over the previous year, certainly 1,000% improvement over where we were 5 years ago. So we also had at that time a discussion around what those performance levels should be for 17. In an effort to continually improve our performance, we set some expectations, and unfortunately, those were pretty high. We regressed from the 78th percentile to the 72nd percentile, and that seems odd to say we regressed. right? 5 years ago, we were talking about hopefully we would get to the 50th percentile at some point in time. We've achieved that. Now we're in the 70th percentile, and hopefully we'll continue to improve upon that. Last year, we had a hybrid model regarding CG caps. CG caps is the overall patient perception of care rating for our clinics, the providers in our clinics. And 50% of that particular goal was based on primary care, 25% on specialty care, and 25% on pediatric care. And our targets were fairly sizable. We didn't achieve that either, and we hit the 28th percentile for that particular metric, and ED the 34th percentile. So we didn't achieve any of the threshold performance levels for that particular pillar at all in fiscal year 17. In terms of finance, we absolutely performed in an outstanding manner regarding DSRIP dollar achievement. We ended the year at 94.3% of all of our available dollars being achieved, and that's fairly remarkable compared to other organizations in the state. And in terms of productivity, we set our target at 5.96 per adjusted patient day to equal budget, and we did better than budget. We came in at 5.9, which exceeded the stretch performance on that particular goal. People, I think Robert talked about that. We've spoken about that in previous board meetings, and the performance exceeded our expectations manyfold. We knew at one point in time that we were going to have a goal to be in the top decile of all performers in the nation. We just didn't know what was going to happen in fiscal year 17. We set what we thought were very healthy performance levels for the year, and the results of that survey that took place in August exceeded all of our expectations. And we exceeded the stretch target of 4.33 by coming in the top decile at 4.36. So these are the measures that were discussed, approved, and that we have been monitoring and measuring and addressing and focusing on all fiscal year 17. So these are the results, and I'm sorry it's so late in the year, but given some of these indicators, there's a significant lag time, and we wanted to be very clear and very sure and validate all of our results before bringing those forward. So that is fiscal year 17. I'd be happy to answer any questions anyone might have about that performance.
Bill, just one question on the falls.
Yes, sir.
I know we post signs, I know we station persons, but I guess I'm trying to figure out how do you prevent them? Because probably more than most board members at this table, I'm in and out of the hospital, not just JPS, but hospitals in the city. And you see those signs at every hospital, preventing the falls. How do you overcome? Because you got patients who think they're well enough to get up and bounce around. And
well, you even have patients in a bed with monitors that unhook the monitors and climb over the rails, and Dr. Ziegler can tell you, I'm sure, stories about that. Preventing them would be ideal. How you minimize those that have injuries is certainly something we focused on. We have hundreds of falls that occur in the year. Visitors, employees, patients, and it's an all-out effort to minimize those. And being the humans that we are, I don't know how to prevent them. I think we need to continue to focus on thinking about how to prevent them, but I don't have a secret sauce on that. I just know that our staff is vigilant. They watch, they know when the conditions are right for certain patients to be at risk to fall, and they take special precautions to ensure that they have something monitoring them, or an individual in the room, line of sight. All of that goes into that. But I've never been a part of an organization that had this few falls with injuries before.
Maybe we might want to consider those places where they have the kid events where you jump off in the foam and you don't get hurt, that we just put those around the bed, so.
Well, if that were the only place the falls occurred, yeah, might help. But they occur everywhere.
Yes. Okay.
It's particularly challenging because we used to use a fair amount of restraints, like a lot of people, but now there's a big push to take people out of restraints, which makes it very challenging.
Yeah.
Okay. All right.
Dorothy, any more questions for Bill?
No, I think Bill
Then-
did an excellent
Okay.
presentation on it.
Bill, thank you, and I'll let you finish your
All right,
area.
turning to fiscal year 18. Now, this might be a challenge in and of itself. We had it up there before. No.
So
not
we
gonna
can just
work.
talk through that one.
Yeah, let's just talk
Talk
through
through
it.
that one.
Because each of you received a proposed template in your board books, right?
It's out
And
there on the board.
Dorothy and I have spoken about that at length, and I think we've got those to pass out, do we not, Scott?
Right. Yeah. Right. it was
We
also-
discussed it at length in HR, and staff proposed metrics for next year. We proposed that, given our success in reducing falls with injury and in reducing the overall catheter-associated urinary tract infections, that we change those goals to goals that we really have more opportunity to improve upon. And we recommended that we change those goals to surgical site infections. Surgical site infections for colons and surgical site infections for abdominal hysterectomies. We also propose that we leave the days to next third new appointment in for our primary care clinics. We've got 12 of those clinics, and we think it's awfully important that we get patients in much less than 25 days.
I had one.
Jeff tells me it is now available, but this clicker does not work.
Just go on. You got it.
H-caps, CG caps, ED caps, we're going to recommend that we continue to monitor those with a little variation. We really want to focus on primary care overall rating. We don't want to blend it with specialty care, don't want to blend it with pediatrics. We just want to focus on how the primary care physician is performing according to our patients in the clinics. ED caps, the variation there is we want to compare ourselves to other level 1 trauma centers. It's very difficult to find a large comparative group of other like-sized EDs in the nation. There's not many of us that are level 1 over 120,000. So we want to find a group that's more like us versus other EDs that are in hospitals that are smaller and don't see the volume of patients that we do. So we found a comparative group in NRC Picker of other level 1 trauma centers that were seeing patients greater than 75,000 in volume. Still almost 80% of the volume that we see, but that's a better compare group than what we historically compared to. And you can see if you look at the way we performed in 17, the percentile ranking is much higher for us in this group than it was in the group that we were comparing ourselves to in 17. Finance, we want to look at adjusted patient day productivity one more time, and we want to include a hospital operating margin. We haven't done that in the past. We focused on DSRIP dollars, but given the uncertainty of DSRIP and where that's going, it's a component of whatever operating margin we might achieve. And we also want to, in some way, shape, or form, continue to monitor employee engagement. We think that's extremely important, but we also understand that it's going to be incredibly difficult to continue to move that as we progress. The top decile is pretty important. It's pretty significant, and to move that yet to the 91st percentile is going to be very, very challenging. So in looking at the stretch targets, we would like a little bit more time to consider what those stretch performance levels might look like for each one of those goals, to consider perhaps, as you can see at the bottom of that graph, yet another employee metric, not take away from the engagement goal, but perhaps add another metric
to the incentive plan for fiscal year 18. So over the next few weeks, we'd like to consider the stretch targets and another goal for employee engagement, or for the people pillar, and bring that back at the January meeting of the HR committee. But in the interim, I would propose that this board consider at least approving some of the performance levels that we have for the goals referenced there at the threshold level and the target level.
Okay, thanks, Bill. I would like to make that as a formal recommendation that we as a board approve the incentive proposal for 18, but knowing that I'm going to have to bring it back, we're going to take it back to the HR committee to look at the stretch. And what we're trying to do is set up some parameters so we don't have to do this every year. Just set up some rules and say, here's what stretch is going to be, here's how it's going to be calculated in the future. We might have to come back and tweak it or back, but I think it's very important that we do that. So that's one of my recommendations, that we as a board approve that. And the second part of that is to approve the payout for the annual plan as recommended by the staff. Okay?
You need two separate.
You need two separate ones?
They're going to be together?
They can be together?
Then basically, then coming from HR, Dorothy, I'll take that as the recommendation. And do I have a second? I have a second. Reverend Emerson. Okay. Is there any discussion, Dorothy? Is there anything else you need to add or anything?
Oh, DT was asking me something. I just wanted to make sure that you want to ask your question before we.
Yeah, I was looking at the very first one, the quality side.
Right.
I was just questioning, should we look at all the SSI or just these particular two? Because orthopedics and heart and all that stuff is a challenge also as well, because it ties to the supply side. I was talking about earlier before about the loaner tray and all that stuff. That can create a lot of infection. So I'm not sure, do we want to take a look at the whole thing, or do we just want to isolate on the two events?
Well, those are the two areas that we have the greatest opportunity. And those two areas have a lot to do with our leapfrog metric as well.
Right. But the other one can help with the margin down at the bottom.
What I would suggest is that we are going to be meeting, having a separate meeting from the HR committee to talk about the some of this proposal. Not this whole proposal, but maybe we could have a discussion included on that, because part of what you are, I believe we monitor it, but it's is a part of some of the other indicators that we look at, what he's talking about.
These are the two that have the greatest degree of opportunity for improvement. The others are doing within observed or expected ranges.
Bill, why don't you come up to the podium here just in case, so our live streaming audience can hear.
All right.
I thought they were also mandated by CMS, these two particular.
I don't know about that.
So if you look at things like orthopedics, their opportunity for improvement is not nearly as great as the surgical site infection for colons, for abdominal hysterectomy. So we're focused on those two areas that could give us the greatest degree of improvement from our patient safety perspective.
Because I was looking more from a operation efficiency when you look at orthopedics and maybe heart surgery and all that stuff, because those things delay surgical time, start time, and it's also tied to how they treat loaner tray and all that stuff. That can create problems from that standpoint, from the process standpoint. So.
Dr. just all on DT, hopefully that's answered some of your question there. You're going to come back when you look at the stretch and all that.
Right.
HR's took a lot of work done. You've done a tremendous job. That committee has been in a lot of meetings. You've been up here 2 or 3 times a week. What we want to do here is based upon the motion, the second on the floor, is approve the 17, but you are going to come back and talk about the stretch goals and those type of things is what you want to bring back.
That is correct. And I think as a part of that, I'll be able to answer some of DT's questions.
That's what we should be able to incorporate that at that time.
Got it.
No. Okay.
Okay.
Any other discussion, motion, in a second? Yes.
How do you document or determine the quality and the accuracy of your data collection?
We have a team that, well, that's their full-time job. They do nothing else but validate data, abstract data from Epic, ensure that the accuracy of that data is valid before they submit any reports. And sometimes that delays reporting a little bit, but I'd rather have a delayed reporting than errors. So we've got several folks that do nothing but, and they're the ones who are responsible for submitting data to our leapfrog measures, and we want to be absolutely certain that's valid.
I'm glad to know that there's somebody dedicated to doing that. Good.
Good.
Thank you.
And again, for clarification, we are approving the 2017 results here. A lot of that additional stretch in the 18, HR will be addressing that, and we'll be coming back to the board for that. If there is no other discussion, I have a motion, a second. I entertain. All those in favor say aye. Aye. Opposed, no. Thank you all so very much, and that also clears item K that was on the consent agenda.
I do, Mr. Chair, if you don't mind, I do want to thank Dorothy and Bill and the other team members. Dorothy and Bill have gone to church together. They have been on picnics together. They went on a camp out together. They have become very, very close, and there were even some comments in the community. But I'm very pleased with the effort that those two individuals took and a lot of other team members. You all as board members need to know that that was yeoman's work on behalf of Bill and the team and Dorothy and the team, and they both did a good job, and I'm very appreciative.
Robert, you beat me to it, but I want to say the same thing. It's easy to say, well, they had a bunch of meetings. Dorothy's not going to say how many she had, but she had a bunch. I'm talking about just the normal scheduled HR meetings. There was a lot of work and preparatory work. Dorothy, I appreciate that. I know Steve, there's been various other people called in. Trent, you've been involved. Again, I appreciate the committee's work. It has been a lengthy, but I'll end by saying this, and I just mentioned Trent's name. Trent, correct me on this, but I recall under your leadership and then followed by Ralph's, we started this entire metrics back 5, 6, 7 years ago, and look where, you probably know where we were. We've all watched this. We certainly seem to be definitely headed to the quality in what we do. So again,
Which, yeah,
I appreciate you and Ralph getting us to hear.
Difference, and Chuck will remember, and Ralph will remember, and actually even Dr. Floyd will remember.
Mm-hmm.
You know, that very first ED task force where we recognized that there was just a lot of elements that really weren't attached to measurement at all.
Right.
And it was kind of like, trust us and it'll be okay. And the numbers, once we began to collect them, because it took really until we got Epic before we could really even know that the numbers were accurate, because the numbers that we would get from one report were completely different than the last report. So it's taken millions of dollars and a whole lot of talent and skilled people to get to the point that we are, and to the extent that we can actually now look at reliable, measurable data, and then actually not just compare to peers, but best them in many regards,
right,
is an amazing achievement in less than a decade. So yeah, it's been great. They've done a great job.
Well, appreciate that. Yes, Ralph.
Along with that, I think that somewhere I think we need to do talk about a work session, just based on where we're headed. Bill and I'm going to be sitting down looking at the 18 in the stretch. I just think somewhere we need to talk about that as a board, based on where we're headed. I don't know how we put that together, but Trent started that, which was outstanding. So right, I think just as we consider that.
Right.
Yeah, and Ralph, along.
You were 2 steps ahead of me in that chase.
Along one of the things that even came out of the budgeting process, and Robert and I've already discussed this, that we plan to schedule in 18 really a follow-up to destination metrics, because it was kind of through up into 18. We're not just going to stop. We're going to keep continuing to do what we need to do. So now we need to go in and take that 5-year plan that got amended for 2, and now we need to see where we're going. So we will definitely be doing that during 18, Ralph. So,
Mr. Chair, can I ask General Counsel and Dorothy for the clarity of that motion? That was the annual incentive, and that was for the 2017 3-year situation as
The
well.
two-
So
the-
that
yeah.
motion was all-inclusive, correct?
All inclusive of the plans, we have two.
Yes, ma'am.
Okay.
Yes, ma'am. I just want to make sure, because I was looking at the eyes of some of the staff members, and some were crossed and some were up in the air, and I want to make sure that we were all okay on that.
Which are the issues discussed in HR that you
Right.
brought forward as a resolution?
Yeah.
Fair.
And I would just like to say, I want to thank staff for continuing to understand and work with me when I have questions. I really appreciate that. I know that sometimes, and it's been handled very professional. So I just want to publicly acknowledge that and thank staff.
Thank you. Thank you, Dorothy.
Thank
very
you,
much.
Dorothy. All right, other matters requiring board action. We'll now talk about, speaking of 17, we'll talk about the audit. Sharon?
Mr. Chairman, as Sharon comes up, I'm trying to remember, Mr. Norad, if you have met Chris Clark, but Chris Clark is coming up. They are not the singing Clarks or anything else. They are not related. It just happens to be.
We can sing, though, if you'd like us to.
Yeah. Chris has been affiliated with JPS from a BKD standpoint for the past 3.5 years. He's also been at BKD for since 2008. He's been with that program. The connection that I have to Chris, which he is unaware of, he is a proud graduate of the University of Central Arkansas in Conway, Arkansas, the proud alum of Bruce DeBear. And the one thing that's interesting about Central Arkansas is my car broke down in Conway, Arkansas one time in college, and I spent 3 days there because I could not afford to get my car fixed. So you may have been...
It's not a bad place to break down if you're going to break down somewhere.
Well, yeah, now looking back retrospectively, you may be right. But I do thank Chris for his efforts and the professionalism by which that audit comes about. We can joke here, but they're very serious about their team, and they're very serious about the questions they ask us, and they're very serious about the work they do. And Chris and Sharon have a good working relationship, and that means that they, to Dorothy's point, they ask a lot of questions of each other, and there are various times when it gets a little tough, and there are various times when they are right on the same page, moving in the same direction. So I'm proud of, obviously, both of y'all. But I did, for Warren's sake, I did want to introduce Chris, because I don't know that you had met Chris from BKD before.
All righty.
Appreciate it. Nice to meet you.
Either one of the Clarks. Yeah, go ahead.
Thank you for pointing out the non-relationship. I would not have thought to do so. But no, I've had the opportunity to work with Chris before coming to JPS. He actually was my auditor with BKD during my time at Cook Children's as well. So,
Mr. Keeley can't hear, so let's make sure we either move a mic towards you
okay,
or get you
I
here.
can.
I'll tell you what.
I think that one's taped. This one's on, so I think they've turned it up. Can you hear me now? Is that better? Thank you. Now I have a big one.
Dr. Ziegler.
Thank you. No, I was saying that I do have the, I've had the opportunity to work with Chris during my time at another organization. So this is the second time. But BKD this is the 6th year for them to perform the audit here at JPS, and Chris has been involved in all 6 of those. He's been the audit partner, I think, for the last 3. And we've had a very consistent team this year. I think what makes BKD a little bit unique in Texas is that they do have a good understanding of some of our federal programs, which is magnified when you are a public facility. And he can tell you a little bit about their clients, but I believe that they audit all of the larger public facilities in Texas. So that gives them especially not just during the audit, but we do use them as a resource during the year for some of our questions, kind of a sounding board for some of our more technical issues. But I'm going to turn it over to Chris and let him present to you guys as an independent auditor, and feel free to ask him any questions of us. Thank you.
Thanks, Sharon. And thank you to the board for having us back again this year to do the audit. We appreciate the opportunity to work with JPS. I'd also like to thank Sharon and Gina Adler and their team in finance for the work that they do. The audit process is very labor intensive for them, and they also have their day jobs that they have to do. But when we arrive to do the audit, they're always prepared and ready, and they are quick to respond to our questions and our data requests and all that type of information that we have to do the audit. So we appreciate that cooperation. You should have in your materials. Sorry about that. You should have in your materials a draft of the audit report itself, and then also a draft of a letter from BKD to the board of managers of the hospital district that's going to give you a narrative of some of the things that we're going to discuss this afternoon. I want to start by going through the required communications, and then I've got some summarized financial statement information and some key ratios that I'll show you in terms of how you've performed historically and how you compare to your peers in the industry. So to begin, I want to just state at the outset that we are prepared to issue an unmodified opinion on the financial statements. That means we're issuing a clean opinion. BKD is giving a reasonable level of assurance that the financial statements are accurate and complete, and that the footnote disclosures contain all the information that a user of the financial statements would need to have to be able to better understand the financial position of the organization. At the beginning of every audit, we go through a risk assessment process, and part of that risk assessment process is evaluating your accounting policies and practices and how they compare to the industry. Sharon mentioned that we work with a number of other hospital districts in the state of Texas, and particularly when you're getting into programs that are unique to Texas, like the Medicaid waiver, like the Medicaid DISH program, other things like that. It's important that your organization is accounting for those transactions consistently with what your peers do, so that you've got a good frame of reference and comparability. We do believe that your accounting policies and practices are both consistent with accounting standards and consistent with what we see in the marketplace. Another required communication is there in the third bullet point. We had no difficulties that we encountered in conducting the audit. I mentioned the level of cooperation that we get from the accounting team here. There were no contentious accounting issues or disagreements with management or anything of that nature, and we did not consult with any other CPA firms in the course of conducting the audit. Lastly, on this slide, we're required to communicate any material written communications between BKD and JPS. One is the letter that I referenced earlier. The second is a document that Mr. Early and Sharon will sign indicating that they believe that the financial statements are accurate and complete, and that they've disclosed to us anything that we would need to know in order to conduct the audit. I've already touched on your significant accounting policies. Those are discussed in more detail in footnote 1 in the financial statements. Key significant disclosures is another area that we spend some time on. I mentioned the footnotes and the accuracy and completeness of those footnotes. It's important, particularly when you have the nature of the Medicaid reimbursement programs that we have here in the state of Texas, that those disclosures related to that program contain all the information that they would need so that a user of the financial statements would better understand the nature of the revenue and the risk associated with that revenue. We do believe that the information that has been included in those footnotes is reasonable and appropriate. And then also the nature of your pension plan, because of the nature of that liability, it's important that all of those disclosures are accurate and complete. They're very complex disclosures as required by governmental accounting standards, but we believe that those disclosures that have been included are comprehensive. We had no adjustments that we proposed that were recorded in the financial statements, so the financial statements that you see in the audit report should be reflective of what was reported to you on an interim basis by the management team. We did have a few areas where we identified variances that we evaluated for materiality, and we look at those both individually and in aggregate, and if we were to conclude that those adjustments, if they're not booked in the financial statements, would be misleading to a user, then we would propose to management that we record those adjustments. We've summarized those in the materials, and there's 2 or 3 of those, but based on the factors that you see there on the screen, concluded that those were immaterial to the financial statements and concluded that it was reasonable not to record those. I want to spend a couple of minutes talking about the significant risk areas in the audit, and I've listed those here on the screen. Patient accounts receivable, self-insured reserves, which includes medical malpractice, employee health claims, and workers' compensation claims. Third-party payer settlements, which includes cost reports and settlements associated with the various waiver programs, your net pension obligation, and then internal control-related matters. So I'll touch briefly what we did in each of those areas and then what our findings were. In terms of patient accounts receivable, the first thing that we do is look back to see how accurate the prior year estimate was. If you collected roughly 100% of what your prior year estimate was, and that gives us confidence that the methodology that you're using internally is reasonable in terms of preparing that estimate. We did find that you collected roughly 100% of what was recorded last year at this time, so that gave us confidence in the model that your management team uses to do that valuation. Based on historical collection trends and an analysis of the model as of 9/30/17, we concluded that the value of the patient accounts receivable that was recorded was reasonable. In terms of self-insurance reserves, we look at actuarial reports, claims history. We have correspondence with your legal counsel to evaluate claims that might exist. All of those liabilities that were recorded appear reasonable to us based on your claims history. In terms of third-party payer settlement programs, again, in the first couple of years of the waiver, there was a lot of delay in the timing of those payments. Now, Medicaid DISH and Medicaid UC payments are much more timely than they were, so there's not as much of an estimate to be made there. But we do believe that what you've recorded at year end is appropriate. We were able to validate a lot of that based on what was paid subsequent to year end. Our only recommendation in this area, and this is something that's not going to be news to anybody, is that the team here constantly evaluate the circumstances that exist with those programs and consider that as it relates to recording any reserves related to audit risk. In terms of your net pension obligation, we spend a lot of time evaluating the census data that the actuary uses to prepare that estimate, and also the assumptions that the actuary uses to prepare that estimate. And to give you a sense of why that's important, the net pension obligation that you've got recorded in your balance sheet today is about $13 million. If the actuary adjusts the discount rate down by 1%, you've got roughly a $10 million net pension asset. If it increases by 1%, that liability increases to about $42 million. So there is a lot of judgment involved in preparing that estimate, and so we want to make sure that the assumptions that are being used are consistent with industry standards and make sense based on what's happening in the market, and we do believe that the assumptions that were used were reasonable. Lastly, on this slide, we spend some time in the risk assessment process evaluating your internal control structure and walking through transactions to evaluate key internal controls. We found no deviations in your practice in terms of the documentation surrounding your internal control structure, and had no significant internal control findings that impacted the audit procedures that we performed. Before I move on to some numbers, any questions about any of the comments that I've made so far? Okay. The next several slides will be some condensed financial statement information. I wanted to start by summarizing for you a peer group. In some of the slides, you'll see a Texas peer average, and that average is based on these 5 entities, which are the 5 largest hospital districts in the state. And just to give you a frame of reference, we've shown here the total assets, total debt, total revenue, and total discharges of those organizations. Obviously, the circumstances here, each of these districts is different in terms of the demographics of the market that they're in, the payer mix, the other providers that are in that market. So there are a variety of reasons that exist for differences that you see there. Probably most notable, if you look at total assets and total debt, the outliers in this group would be Parkland and UHS in San Antonio. That's because those 2 organizations have done large bond issues to fund large facility projects. So that's why their total assets and total debt look so different from JPS. This is your balance sheet over a 5-year period, and we think it's important when you're evaluating financial performance and financial position that you look at historical trends, and so that's why we include 5 years in these slides. A couple of things that I would point out just in terms of changes that have occurred. You can see in the second line there your Medicaid receivable, a big drop from 2015 to 2016. That goes to the point that I made just a few minutes ago about the timing of when payments were being received. Back in 2015, your fiscal year ended before you had received a big portion of your Medicaid DSH and UC funds. At the end of 2017, nearly all of those payments had been received, so that's why that receivable is so much lower. In 2016 and 2017, the largest piece of that receivable is your DSRIP-related receivable that is for the 6-month reporting period ended September 30, 2017.
If it wasn't received until FY17, wouldn't it show up in 17? The Medicaid receivable?
The revenue is recorded in 2000.
That's the receivable. Okay.
Right.
Got it.
Yep. So at the end of at September 30th, you had essentially earned 6 months worth of DSRIP funding that wasn't paid that won't be paid until 2018. You can see in 2017. Yes, sir.
Assuming that these numbers are in millions of dollars?
They are in millions.
Okay.
Good point. In terms of other changes that you might notice in the balance sheet, in 2015, we adopted a new accounting standard that required your net pension obligation be reflected in your financial statements. That's why you see a deferred outflow of resources and then an increase in the other liabilities line down in the liability side of the balance sheet. That's where your net pension obligation is recorded. Over this 5-year period, your total assets have increased about 14%. Over that same time period, your total net position or equity has increased by about 13%. So that growth in your balance sheet, obviously because you've issued no new debt, the growth in your balance sheet has fallen straight to your equity position. One other thing that I might point out here, you'll notice a pretty significant increase in current liabilities between 2017 and 2016. A large reason for that is that in 2017, the Local Provider Participation Fund was created, and you accumulated cash from other providers that will be used to fund Medicaid programs through an IGT, and that IGT will be made in 2018. So you had about $25 million of cash from that program that's up in cash, but then you also had the related liability that increased your current liabilities. Sure. Yeah, we'll look at another slide here in a second that I think will also help to show this, but you did have an increase in 2017 that's primarily attributable to a claim, and I'm glad you asked that question because these financial statements that you see are essentially combined financial statements that include both the hospital and a claim. It's really due mostly to the growth in a claim during 2017. Here's a look at days cash on hand over a 5-year period. You can see steady growth between 2013 and 2017. You were at about 216 days cash on hand. So this means that if no other cash were to come into the organization, you could operate for 216 days based on your current expense structure and the amount of cash that you have on hand. The green line there is the average for the 5 districts that I mentioned earlier, so a little less than 200. There's a couple of things here that I would point out that will impact this average. There are 2 districts that have different year ends than you. UHS in San Antonio has a 12/31 year end. Harris County has a 2/28 year end. And if you think about the timing of when property tax revenue comes in, those organizations are going to have a lot more cash at their fiscal year ends than what you do at your fiscal year ends because you don't have that property tax revenue yet. So that's going to skew these numbers a little bit. You can see, if you look at it from a Moody's perspective, you're right in line with the average for Moody's rated hospitals, a little bit higher than the average Moody's hospital and a little bit lower than the AA3 rated Moody's hospital. In terms of net days and accounts receivable, you can see back in 2013, you see the drop to 2014. That's when your EPIC implementation occurred. Since that time, you've hovered in the low 50s, which from a valuation perspective and process perspective is very reasonable and consistent with industry standards. When we look at this, we look at it from both an operational efficiency perspective. So if you see a big jump, there's could be two issues at play. One, there's weaknesses in your revenue cycle, or there's a valuation issue. Given where you are today and where you've been and how consistent that is with your peers in the industry, I would say that that's a good position to be in from an AR perspective. You are a little bit lower than the average for the districts. UHS in San Antonio has a program that essentially works like a revolving line of credit for uninsured patients. So their AR is a lot higher because they have programs that where their uninsured patients will pay over an extended period of time. It's a very formalized program, but that drives their net days and up, and that drives that industry average up.
Turn your mic on. For the AR side of it, with the majority of the payer that we have is Medicare, Medicaid, and JPS connection.
Mm-hmm.
Should we look at a lower AR days than a normal Moody, because that's include a lot more commercial on the other side?
Your Medicare, that is a valid point. Your government payers tend to pay a little bit quicker than your commercial payers.
That's 7 and 14 days. Mm-hmm.
That's probably on the very quick side.
We need, from I'm looking at it, do we need to improve on the CDI side of it, or do we need to improve on the appeal process of it?
That's probably a question that I can't provide a good answer to. We don't get into the operational aspects of the revenue cycle when we're doing the audit. We're looking at it purely from a valuation perspective to make sure that based on your historical collection trends, you've not overstated revenue by overstating the value of accounts receivable. Based on where you've been and where you are now, I would say that the EPIC implementation created a lot of efficiencies that maybe you didn't have before in your billing cycle. If you look at that peer average, you're lower than the other districts in the state on average, and there's maybe some reasons for that, like the program down in San Antonio that I mentioned. But even if you were to pull that out, I would argue that your average time to collect is very consistent with other districts who have very similar payer mix to you. Some organizations have a lot higher uninsured, and so maybe their net days are lower because they write off so much more of their accounts receivable. But for the others that have a very high concentration of government payers and uninsured, you're right in the ballpark of where those organizations are.
Well, what I'm concerned is, not concerned, but trying to see if we can find improvement, because sometimes when you're a level 1 trauma center, then the documentation and the appeal process takes a lot longer.
Mm-hmm.
But I'm just trying to see the delta between that, because sometimes it's better to hang on to it and get the most you can get rather than just accept what you got. But I just don't have an idea, so I thought you might have some visibility on that.
You know, that would probably take a revenue cycle assessment to get good answers to that question.
Thank you.
I just want, just for the record, I want you to know that the fact that Mr. Wynn asked you a question and you didn't know the answer made the entire staff very happy. We try, and we are so excited. They're all joyful.
No, it helps us to understand.
I'm going to research that, though, in the next audit, and I'm going to come back and have an answer to that question.
Well, no,
so.
You'll have that one. I got it.
And you're on record, Chris.
This, I think, as a governmental entity that has a defined benefit pension plan, is a very important metric to evaluate, and this is funded status. You can see JPS is the maroon bar there, and at the end of 2017, you were about 93, 94% funded. That compares to the average for S&P, which is just over 70%, and the average for the other your other peers in the state, which is about 80%. So you're in a very secure position from a funded pension standpoint. I've read articles that have said that the average government, not just government hospital, but average municipality, the average funded status is in the 60% range. So you're in a strong financial position related to your pension plan, and it would be the envy of a lot of organizations. Another way to look at your cash is to compare it to your long-term debt. So this slide may be a little bit confusing. The maroon bar is your cash, and the blue bar is your debt. You've not done a debt issue in a long time and have very little debt, obviously. So that's why you see that big delta. The green bar represents the average amount of debt that other districts have based on your level of cash. So it's basically taking the average cash to debt ratio and applying it to your cash number. So you can see, on average, if you take the 5 districts and you pull that down a little bit because you don't have any debt, the total amount of debt is a little bit higher than cash. And then for the average Moody's rated hospital, you see a ratio of about 160% cash to debt. The green bar obviously jumped up a lot when UHS and Parkland did their bond issues. Here's a look at your income statement. Over the last 5 years, this year you reported a total net loss of $4 million. A couple of things that I would note here. In terms of net patient revenue, you've grown from $261 million in 2013 up to $396 million in just this 5-year period. That's a 51% increase. And if you look at the next line there, your supplemental Medicaid funding, this is DSRIP, and you see primarily, you can see you had $211 million back in 2013, and that's dropped $62 million to just under $150 million in 2017. You've also had a 24% growth in your property tax revenue in that period. But clearly for organizations like yours and really for a lot of governmental rural hospitals in the state of Texas, that supplemental Medicaid funding line is key and really the area of most concern that we hear being discussed by management teams and boards as they look into the future. It's very hard to plan strategically at times when there's so much fluctuation in that figure. Another way that we like to look at patient accounts receivable and your revenue is comparing cash collections. If you've collected the same amount of cash that you've recorded as revenue in your financial statements, there's no better proof than that in terms of auditing revenue. And we will look at this in individual years, but also over an extended period of time, because you're going to have years, especially in years of growth, where your net revenue exceeds your cash collections, and then it'll tend to make up for itself in future years. So if you look at this over this 5-year period, you've collected 101% of the revenue that you've recorded in your financial statements. That gives us a lot of confidence that what you've shown as revenue is accurate. Really, from a analysis standpoint, you want to see this stay between 98 and 102% over any 3 to 5 year measurement period.
So this factors out the uncollectibles, the stuff we write off.
Correct.
Is there a concern that our chart master is lower than what we should be?
That would require a charge master review, which we have not done. This chart shows your uncompensated care to gross revenue, really very consistent over the last few years. You saw a drop in 2015 where I think you had more patients that signed up for plans under the ACA, so that's why you see that drop in uncompensated care in 2015, but real consistent in terms of the level of charity care that you've been providing here over the last few years and the amount of bad debt expense that you get from patients that don't qualify for charity but also don't pay their bills. Lastly, I'm showing here your reliance on property tax revenue, both from a total dollar standpoint and also a percentage of support standpoint. So that percentage is calculated based on property tax revenue to the sum of operating revenue and property tax revenue. Clearly, there's differences in each of these markets that cause the total dollar amount of revenue that's required from property taxes and also the percent of support that generates. This is impacted by the amount of supplemental funding that each of these organizations gets, but gives you an idea of how you compare to your peers in the industry in terms of your property tax support. My last slide here is just a list of a few things that we see as challenges in the industry and things that are happening right now. Really, I'd probably focus in for this organization on the top two. Congress is clearly looking for ways to gut the ACA, and you see in the current tax legislation that's been proposed, repealing of the individual mandate, which has an effect on the marketplaces and the exchange plans and the viability of those plans. And then the Medicaid waiver renewal. Currently, the waiver period ends on December 31st of this year. We have heard that there is tentative approval of a renewal plan, but there's disagreements between the state and CMS over how uncompensated care costs are going to be calculated. This state can't function without those funds, and so I don't think there's an expectation that there's going to be no renewal, but clearly in terms of the dollar amounts that will come into the organization, this is an area of concern. Be happy to answer any other questions that you might have.
Do you audit the cost report also as well, or is it out of scope for you?
You prepare your cost report internally. So we look at the cost report for purposes of evaluating estimated payables or receivables. CMS comes in and audits the cost reports from time to time, but we don't actually audit the cost report itself.
My question is wrapped around the bad debt expense. I don't see it on the report, so are we in line or not in line?
I would probably refer back to this slide. Bad debt expense is, it's not a separate line item in the financial statements, but if you look at the income statement itself, which is on page 11 of the audit report, we disclose what that is. It was $326 million in 2017 and $307 million in 2016. And then there's a disclosure in the footnotes that tells you, okay, those are the charges that were written off, but what's our actual cost associated with that? It's hard to, I would say if you look at the average bad debt expense for S&P rated hospitals is about 6%. You're just over 10% here, but their level of charity care is much smaller. So I think it's important that you look at your bad debt expense and charity in aggregate. You're going to be different from other large hospital districts just because of demographics in the market that you're in. But I would say, based on your mission here and the property tax revenue that you generate to fund your uncompensated care costs, that this is a very reasonable level of uncompensated care.
I had a question earlier. I think it was on the property tax slide. Could you put that one back? Why is it 37% above the red and all the others are less?
Well, again, that's going to depend on the uninsured burden that you have. It's going to depend on the amount of supplemental funding that you get. So some of these organizations might get more DSRIP revenue that you get. So the percentage is just to give you a sense of how much of your revenue in total comes from property taxes as compared to the others.
Good. You okay, Rick?
The red?
If blue versus red, the red is just to highlight JPS on the chart. There's no other reasoning behind blue versus red.
All looks great.
Yeah.
It is good. I mean, those are good numbers. Just the distinction of that color. You might want to go with the purple.
I'll do that.
It's not negative.
You're not in the red.
Poor world. Yeah, it could go with maroon.
Chris, I'm sorry, we're losing the floor over these things. Rex, any other questions? Is there any other questions for Chris in this regard? Anyone else? Then, Chris, anything else you need to present? If not, Mr.
Chairman,
Montgomery?
I want to thank Chris and thank Gina and Sharon for your hard work on this. Thank you for the presentation. Very
Thank you for
good.
having us.
And for fielding DT's questions. Thank you. Mr. Chairman, I'd like to make a motion that we approve the audit.
Should I have a motion?
Second.
I have a second by Dr. Hire. All those in favor say aye. Opposed, no. Thank you. Chris, thank you very much. And again, I know y'all look at a lot of those things in finance, Steve, and I appreciate it very much.
I figured if I was late today, I need to do something.
Trent and I were interviewing BKD. They have a book that is required reading by all their partners, et cetera. Isn't that correct? That's correct. It is well worth looking at from my standpoint. It was good to see the level of integrity and what they had in the book. So anybody that hasn't read it, it's not very big. I would encourage you to take a look at it.
Good deal. Super. Chris, thank you very much.
Thank you, Chris.
Thank you, Chris. Next item is number B, approval of the Quality Assessment Performance Improvement Plan. And as I indicated at the start of this meeting, as you know, we are required annually to approve a lot of various policies and any other procedures. So, Wanda, thank you all so very, very much for coming up. And Scott, thank you.
Good afternoon, Mr. Chairman, honorable members of the board. My name is Mona. I'm the Executive Director of Quality here at JPS. As a follow-up to last month's board meeting, the fiscal year 18 Quality Assessment Performance Improvement Plan has been made available for your review. Today, I would like to request the board to consider approval of the fiscal year QAPI plan.
Any discussion? Not, I'd entertain a motion. I have a motion by Dr. Weber. Second by Mrs. DeBose. All those in favor say aye. Thank you all so very much.
Thank you.
Your best presentation.
Yeah, well,
Very proud of you.
Thank you for
I
coming
presented
up.
yesterday.
All right, thank you, Wanda. The next one is item number C. And Robert, I'll turn that to you. It's as we know, we appoint Mr. Rule to a lot of things. So
Yes,
I'll let
these
you go.
are some of the new TIF renewals that we will be appointing, with your permission, Mr. Rule to. He is the one that serves on all of our TIFs, and we want that from a consistency standpoint and also from a comparison standpoint. So if you all would consider Mr. Rule to be appointed to those TIFs, I would appreciate it.
I have a motion by Mr. Petty. I have a second by Dr. Weber. All those in favor say aye. Thank you. Congratulations, Scott, which will bring you up to item number D, approval of the letter on the foreign trade destination.
Terrific. Good afternoon. Mauser Electronics is a leading worldwide distributor of semiconductors and electrical components, and Mauser has a facility in Mansfield in Tarrant County. And they would like to include that facility in the Dallas-Fort Worth Airport Foreign Trade Zone. Mauser has agreed to reimburse the Tarrant County Hospital District for taxes otherwise exempted under the Free Trade Zone. And the agreement memorializing that intent is before you today.
Any questions for Scott? Yes, Trent, you know.
Turn that mic
Yeah.
on.
This can appear as a zero-sum game, but the fact is they reimburse the local property tax burden because by being in the foreign trade zone, they still get the benefits of the federal tariff and federal duty offsets that occur inside a foreign trade zone. So to the question of why they're doing this and then reimbursing the taxes, that's the answer.
Do we put on some sort of a schedule, calendar to come back and see if we're getting our the funding we should get, because I see promises like this and even written agreements like this and public pronouncements like this pretty routinely where we never get a dime back from, in other organizations. I'm sure, I just want to hear the reassurance that we're going to get our.
Let me address that a little bit. If you look at paragraph 6 of this agreement under security, it provides that the district will receive either a letter of credit or a bond, payment bond. And I just received a copy of the actual payment bond that's in fact been issued for $600,000 to the district from Travelers. So you have the best security you could have in a payment bond. So it's there.
Did y'all have this question and answer set up before you asked that question? Because I just want to make sure. So
if they did, it's the first.
I actually Scott sent this to me a few minutes ago. So.
Well, good point in raising the question. I'm glad we have we're covered. So great.
Need approval.
Yeah, so I need to entertain a motion for approval, Adam. I have a motion by Mr. Petty and a second by Mr. Montgomery. All those in favor say aye. Aye. Thank you so much, Scott. Thank you.
Thank you.
All right, item number E. We've got a bunch of, this is our annual review of policies, so I guess we'll take these.
Mr. Chairman, this is your every 3-year review for JCO purposes. All of this is non-substantive. It's updates. We've actually there have been a few minor changes, but those are making sure that these policies are consistent with current statute. So.
And to Pastor Emerson's point, this was some of these policies that are here was very helpful from the group that we brought in. We have so many policies in the organization. A lot of these literally were grammatical changes and those non-substantive changes, but these are not something that you want somebody to review and say, are they all up to date? That's why you're getting them now. But to my point earlier, it was brought to our attention by the review that we had, but it's also that maintenance policy that JPS should always have towards these.
And they're going to, JCO's going to look, when they come in, they're going to make sure that this governing body has reviewed these your policies, which are yours, on a every 3-year basis. So that's why they're here.
All right, let's go. Item number 1.
Mr. Chairman, thanks to Attorney Adams and Mr. Early. They have provided the context for the consideration of these policies and plan. They are part of our requirements per the Joint Commission, and also they satisfy our requirements from a CMS conditions of participation standpoint. Thank you.
And so I get a legal question here. This is actually on the portal and has also been provided earlier. Unless the board would like for someone to come up and explain each one, we just need individual approval.
You just need individual approval. In addition to these policies being posted to your portal, the supporting procedures that implement these policies have also been posted to your board portal. The red lines of those indicating where those changes have been made and edits. So you've had those before.
If it is the desire of the board, then we would take these in order and just ask for a motion and second. I have a motion by Mr. Montgomery, a second Dr. Weber. All those in favor say aye. Aye. Opposed, no. Item number 2, the abuse, neglect, and reporting cases policy. I have a motion by Mr. Bose, second by Reverend Emerson. All those in favor say aye. Aye. Thank you very much. Next is the policies and procedures, the LD 500. I have a motion by Reverend Emerson. I have a second by Mr. Petty. All those in favor say aye. Item number 4 is the transfusion therapy policy.
Move approval of the transfusion.
Motion by Mrs. DeBose. Second by Reverend Emerson. All those in favor say aye. Aye. And item number 5 is the anti-coagulation management agreement. Go ahead. I'm gonna have Dr. Weber cover that one. Chuck, you want to make that one? Where's the vice chair on that one?
Call your chair
Chair
out.
on the chair. Gosh, that's a tough group. I have a motion by Dr. Weber.
Everybody's invited to the Christmas party except Mr. Montgomery.
Yeah. I'll work on that one tonight, Steve. I have a motion. I have a second. I have a second by Mr. Montgomery. All those in favor say aye. Aye. Appreciate it. Thank you. And the utilization review and care management plan.
Move approval of the utilization and care management plan.
I have a motion by Mrs. DeBose. Second by Dr. Weber. All those in favor say aye. thank y'all so very much.
Thank you all.
Thank you.
But yes,
I noticed that Dorothy moved and said every word of everyone, but she didn't say anything when number 5 came up.
well, don't worry. That's all right, Dorothy. I appreciate that. Really, the vice chair, Dr. Weber over here, should have been, we had him on that one. Item number F. Jamie, would you like to come up and present item number F, purchasing procedure? Where's my Dr. Pepper?
Good afternoon. As discussed last week in the Finance Board of Managers Committee meeting, we had experienced a plumbing failure and the drains in our kitchen backed up in late November. We immediately contacted 3 different vendors to assess the piping and was provided with estimates. Quantum Mechanical provided us with the lowest estimate, and they were able to begin the repair the quickest. The 4-inch cast iron pipe was replaced with a 6-inch PVC pipe. The cost for that was $65,000. The storm drain was incorrectly installed many years ago and was feeding into the 4-inch cast iron pipe. It is being redirected to the proper drainage system in order to prevent future failures. The cost for that is $73,000. Total cost for this repair is $138,000. Today, I'm requesting the Board of Managers to consider approval of exemption of purchase from competitive bidding and consider approval of the agreement between Quantum Mechanical Services Incorporated and JPS Health Network related to emergency repairs of and upgrade to the Tarrant County Hospital District property.
Jamie, thank you. If you were at finance, you know there's lengthy here, but also we had general counsel's opinion that this did fall under the emergency program. Steve, I know it was in finance. So, Jamie, I know you presented this once and had a lengthy discussion. Thank you for being here. That being said, if there's no questions, I'd entertain a motion. I have a motion by Mr. Montgomery, second by Dr. Weber. All those in favor say aye. Aye.
Thank you.
Jamie, they didn't get into all this question like in finance about how old the pipe was and all the problems that built in 19. Anyway, thank you very much for doing it.
Thank you.
All right, thank you. Item number G, approval of professional service agreement. Bill.
Yes, sir. This normally would have come to finance, but we were working out the finer details last week and elected to bring it to the full board. This is a contract for our hospitalist group that expires in February. It is a slight increase. We have budgeted for that slight increase, but we have had some turnover in that area over the last 6 months, and it is volume and acuity based. We've had hospitalists that are leaving for more compensation. That compensation is increasing, it seems like almost every month. Their median salaries are jumping, and we need some provision in the new agreement to allow us to at least try to get them to the 50th percentile, the median of the range, if you will. We also need more, and that really speaks to the volume of patients that these folks are seeing. And there's going to become a point in time that they can't see any more patients, and it's nearing that point right now. There's only so much wall space in the ED for us to put the patients on. There's only so many beds that we have, and there's only so many patients that they can see. But they're seeing, on average, 11% more last year, 11% more this year, and we need to provide in the agreement capacity for additional providers. There's also a provision in this agreement to, if the volume continues to increase, for us to mutually agree to add providers if that volume has sustained itself for a period of 90 days. So it is basically an $8 million arrangement. It's a 3-year contract that would expire in December of 2020. It is now such that we would offset the bills that sound bills for the services here, and whatever we pay them would be offset against those bills. So it's hopefully going to be less expensive for us long-term than it has been historically. Everything else there, I think, is fairly straightforward, but I'll be happy to answer any questions anyone might have in regard to this proposed agreement.
One question, Bill.
Yes, sir.
Is the 15,000, is that a fair comparison with market on the quality incentive potential?
They tell me that it is. I really don't have a way to gauge that. I don't, that's not coming out in the MGMA. It's just overall compensation. So when you add that to the base, it's in the marketplace.
Okay. Thanks.
Any other questions for Bill? If not, I'd entertain a motion. I have a motion by Dr. Weber, seconded by Mr. Montgomery, along with his anti-coagulation management policy. Hey, you know, it's amazing when you stop and think about it. But anyway, I have a motion, I have a second. All those in favor say aye. Opposed, no. Thank you, Bill.
Thank you.
I appreciate it. Consent agenda, as you know, we pulled item K from the consent agenda and approved it individually in Dorothy's area in HR. If there's nothing else, I would ask for consideration of motion to approve the consent agenda as stated. I have a motion by Dr. Weber. Second by Reverend Emerson. All those in favor say aye. Aye. Mr. Adams, is there any issues?
Yeah, I just have one, our monthly announcement. There were 28 contracts under $200,000 that were negotiated for the month of November 2017, and those that list of contracts have been posted on your board portal.
Thank you very much. I'm going to take the liberty as chairman. We're here in December. I think I see her in the very back there. Miss Lisa McGarity is back there, who obviously is with Commissioner Wynn. We appreciate staff of the commissioners being here. I also see Rebecca Barksdale, Commissioner Fickus, and I think who else I missed? Oh, Roderick came in. Roderick Miles with Commissioner Brooks, and then Chandler Merritt with Judge Whitley. So, you know, y'all come to a lot of meetings during the year, and we just want to say thank y'all very much for y'all's participation in these meetings. Rebecca probably won't say anything. I'll get in trouble, but I just saw where she's receiving the Lifetime Leadership Award from the Northeast Leadership Foundation. So, Rebecca, congratulations to you for that also. So, from what I know, it doesn't appear that close will be very long. We do have an item in close with privileges we need to discuss real quick, and so if we want to take a quick 5 minutes, and we'll come back and get this final. Whatever. Oh, hey, I've been working on anticoagulation. Thank y'all very much. We will now reconvene in open session at 3:20. I think one of the first items we have left to do on the agenda is our privileges, and I know they've been discussed. And
I recommend the approval of the appointments, reappointments as presented by Dr. Ziegler.
I have a motion. I have a second by Mrs. DeBose. All those in favor say aye. Aye. All those opposed? Thank you very much. Any other business that needs to come before the board, Mr. E?
Do what now?
The cardiovascular piece in Dr. Ziegler's presentation.
That was part of it.
That was part of it.
Just to be clear, there's the perfusionist credential info. Just want to make sure that's part of it.
Right.
Does he have trouble saying
We'll
that?
just make that part of it. Yeah.
All right, so.
I was
if
very
legal-
remiss in the earlier open session that I didn't commend each one of you. I have 11 responses to the conflict of interest. I don't know that I've ever had that before.
You didn't tell me that other people got away with it.
Yeah, I will say you were last, but I got yours. So I now have 11 signed conflict of interest deals, and that's an annual event from now on.
God.
First time the wrong one, second time.
We got Dr. Howard.
Well, sounds like Dr. Howard got it on the right one.
He did.
Yeah. Then I hear us saying, yeah, again, I hear there is no additional business to come from the board, that we stand adjourned. Thank y'all very much. Merry Christmas.